let's see, Greg Snyder, did I understand correctly that you have the foot of the vasoseal disorder? I'm sorry, I probably meant angioseal. Angioseal. In the case I was discussing, if you deploy the angioseal and the collagen is sitting outside of the dermatotomy, so imagine thin body habitus, the collagen, this is the skin, and the collagen is sort of a knuckle of collagen is poking through the skin. Don't take a pair of scissors and cut the collagen in an effort to sort of cut the suture. What I was saying is take a lidocaine syringe or saline. You just need to inject enough tumescent to sort of create a wheal, fairly large. You have to get the skin up and over the collagen, and once you've done that, you can cut the suture. The case that I showed was what had taken place when, a patient with thin body habitus, they just cut the collagen to make it flush with the skin. And what happened was the angioseal, the foot plate, or the anchor embolized distally. It would probably dissolve, but in the case of single vessel runoff, they went and they retrieved it. Actually, it's not easy to see. That's the other thing. The dimensions of the anchor are 10 millimeters by 1 millimeter. And so it's not a very easy device to find in terms of retrieving. But again, I'm like, if you don't cut the suture or don't have it dislodged through the collagen, the likelihood that the anchor will embolize is certainly, it's not zero, but it's certainly diminished. So hopefully that answered your question. Anyone else? Just trying to see if there are any other questions. I felt like, the subject is, the use of these closure devices. They've been around a long time. One thing it's worth kind of, thinking about is the following. The angioseal was managed by St. Jude for a long time, and then it was acquired by Terumo. And so when you think about Terumo, their expertise as a company in sheaths and hydrophilic coatings is really, I feel like, how they made their name. The Glide wire, when it first came into the market, there was nothing like it. This hydrophilic approach to sort of manipulating through occlusions, it was really a game changer in the world of endovascular care. And Terumo was a step ahead of everyone else. And so, they have now acquired this property, Angioseal, and there have been several iterations of Angioseal. And so I feel a natural progression in the life cycle of Angioseal is to take the expertise of Terumo with regard to surface coatings and making things hydrophilic, and their expertise in sheaths. I am a big fan of the Pinnacle line of sheaths. I think they really perform exceptionally well with regard to access. This is not, in some respects, it's not the sexiest place, but to me, like reliability, consistency, like performance, these things matter in terms of, especially if you're in a groin where there's a lot of calcium, or there's been several prior procedures done and there's some scar tissue there. These sheaths really perform quite well. And so the idea that Terumo will take some of this sheath technology, some of this surface coating technology, and bring it to bear on the Angioseal, on the sheath, the vessel locator and the hemostatic sheath for the Angioseal, I think is to me a change which hopefully we'll see bear fruit down in the future. I'm just going to read through Greg Snyder, who had asked the question about the foot plate, and he said, We've been fortunate, never had it embolized. How often are you using Perclose in calcified vessels? Good question. And so, I'm very liberal in my use of imaging of an artery when we get in, understand, okay, this is what it looks like. And so I do use Perclose in calcified vessels. It's not like it's verboten. But when I can see heavy calcium on the angio, already I'm starting to risk manage and say, probably not going to really want to use Perclose here. I sometimes feel like the Perclose device on very obese patients, or if there's a lot of angulation and tortuosity, when you advance the device in, it doesn't, you have to take the wire out and then allow the device on its own to sort of navigate up the iliacs. And I don't think it does well with a lot of tortuosity. My rule on the Perclose is typically we'll put the Perclose in, we'll fire it. If it doesn't fire correctly, I'm usually thinking like, okay, this is not an ideal case for a Perclose. We'll then back it out, put the wire in, and maybe switch to a device, something else. Sometimes switch to StarClose and been happy with it, or Minx. I tell you where I like the Minx device. Certainly in patients that have a very diseased artery, we've used Minx. When we've done cases where we're going to, say, okay, we can stay 5 French, we'll use Minx on some antegrade sticks. Where I've had major problems with Minx, to the point where I sort of sour on the device, is we will have it fail, but unfortunately, it doesn't fail immediately. And so what I typically find is we'll use the Minx, and I'm very compulsive on the Minx. So if the IFU says, oh, you want to hold the balloon and apply tension for 30 seconds, I'm like, let's go a minute. If then we lay the device down for 90 seconds, I say, let's go 3 minutes. And then we deflate the balloon and hold pressure. I'm like, let's hold pressure for another 3 minutes. So we'll sort of follow these steps, and then I'll be in the next case, and someone will come into recovery and say, listen, that last patient, their pressure is now 80, and in which case it's incredibly disruptive, both for the patient that's in the room and then to go out of the room. I really find it, the Minx that's happened enough times. And my approach when things don't work, when there's a complication, when there's a problem, you sort of sit there and you do your own failure analysis. Okay, what am I going to do differently next time? It's like you're the captain of the Titanic. If you could say to the guy, all right, you see that iceberg out there, any thoughts on doing things differently this time? I'm always looking for it, and so when the Minx has failed, one of the things I went to was I thought, okay, on the Minx you pull up the balloon and you deliver the polymer with the pusher, and I actually bring the pusher back because I'm like, okay, we've pushed down. We do not want to create a channel on that polymer, so I hold up for 30 seconds, or I say they won't hold for 30 seconds. I hold for longer, and then I hold. And I make sure that pusher is not sitting down on the balloon because it's just going to create a channel through the polyethylene. In spite of saying, okay, we've now changed practices, we're even more focused on, on technique. I will say this, technique in general, it matters. It matters on the angioceal. On that little video I showed you, I go in, I go out, I go in, I go out. I'm like, you can't do it too many times. As far as I'm concerned, you want to know I'm in the artery. I'm not too deep in the artery, but I'm not in the soft tissues either. I mean, the danger of being way too far in with the angioceal is that anchor potentially can catch the inferior epigastric. They could catch the deep iliac circumflex. And so, I want to be really, where the arteriotomy locator is right in the artery, that I'm 1.5 centimeters. And so when I come out with that anchor, I then slide back. It's going to slide back roughly 1.5 centimeters, and then 1 centimeter more, so, and then deploy, and then I pull. And I'm not afraid to apply some tension on that suture to really bring. I want to bring that anchor up against the anterior wall of the artery. That's my goal. I do not want to deploy that collagen in the artery. It has to be outside. Sorry, I just want to see if there's any more questions. So someone asked, can you comment on the discharge protocol of angioseal? So certainly. So with regard to angioseal, generally patients are flat for an hour. Then we sit them up for half an hour, and then we sort of, but they're still in bed, and then at about an hour, 45 minutes, 2 hours, they're out of bed, standing, changing, and then they're out the door at 2 hours. That's kind of our standard operating procedure. Any question, deviation, issue, concern, ooze, anything, we are willing to kind of like say, this patient, given that extra half hour here, we're not. It is not dogma. We are allowed some interpretation, but generally I try to keep them roughly 2 hours. Let's see any other questions. Anyway, thank you for joining in, and I'm in several locations, and so if anyone ever wants to reach out to me, by all means call the office. I'm happy to give you my thoughts, and thank you for listening.